so now we're going to switch gears and we're going to talk about trauma. And my first disclosure, and I was talking about it with our front row, is that the trauma that I see in New York City is very different from the trauma that many of you may see. And trauma is very much dictated by our geography, right? And so America is a very broad region. And so New York City is very dense. People do not drive, or if they do, they drive very slowly because it's so much traffic. So if we do get car accidents, we do not get car accidents like this. We actually don't have a lot of gunshot trauma because it's a city, things are very regulated. So I am not going to give you the perspective of someone who may be in the American South, like Texas. Texas is where they get the crazy car trauma and gunshots and people in ATVs and four-wheelers. I do not see any of that. I see the complications of that. So I'll tell you more about what some of the nuances of trauma in my practice, which tends to be like old people falling down subway stairs or young sportsy guys, breaking their ankle on the weekends. But I promise we'll still try to make it interesting. But I would imagine I actually have much to learn from you guys about complex trauma. So let's talk about a tale of 2 feet, where the top of my foot hurts. So this lady is 76. She fell down the stairs last week. Her husband is a doctor, and he said, oh, all of this swelling is normal. Just put an ACE bandage on it. You don't need to go to the emergency room. You can just see an orthopedic doctor in the office a week later. And so she has just been walking around on this in an ACE bandage. He was not an orthopedist, so these are obviously really bad fracture blisters. And even though she's 76, she still walks at home. You can tell a lot of people by their toenails. She's got a nice pedicure, so she's still active. So these are her x-rays, which were a week plus out from her injury. Yeah, exactly. So she's got a really bad Lisfranc. All right, so how do we know that? Well, we see nothing too bad at 1. And when I say, so I use a lot of numbering when I talk about toes and Lisfranc. So when I say 1, 2, 3, 4, 5, what I mean is like the first, the second, the third, the fourth, the fifth TMTs, okay? So 1 looks okay. 2 looks like garbage. You can see that 2 is kind of dislocated dorsally here. There's fracture here. This is a non-weight-bearing lateral, which actually doesn't look that bad. And then there's this huge gap between 2 and 3 with fracture fragments. 3 is supposed to be sitting on top of the cuneiform here, and instead it's deciding to go over and kiss the cuboid. And then 4 and 5 are out in left field. Remember, 4 and 5 are supposed to be on top of the cuboid, and they're dislocated out this way. And we've lost the normal architecture of our cuboid. So she's got a really bad Lisfranc fracture dislocation. She also has an old 5th metatarsal fracture that healed. So even though this isn't a car accident, for this little, petite little grandma lady, this was a big accident for her. And, can I have you individually click on each of these videos? Sorry, I brought videos of my CAT scans, which may have been, do that one first. Yeah. So we'll scroll through. So you can see here, 1 is subluxed, 2 is fracture dislocated, 3 is fracture dislocated, 4 and 5 are dislocated, and she's got a cuboid fracture. Can I have you click both of these, please? You can do the one up top too. We can look through them in sequence. So 1 is kind of is partially subluxed. Again, you see everything at 2. Base of 2 fracture is not uncommon. 3 is up in the air. It needs to be down. All right, great. Oh gosh. Okay, so the first question, even before we get to do our surgery, is, with these wounds, what are you thinking? Are you worried? Are you not worried? Does that change what you do? Does anybody have thoughts?
The trauma mechanism is very high energy.
Yeah, it's higher energy for this little grandma, right? Totally. So does that change what you want to do? She's sitting dislocated. We can't leave her foot like that.
With that blister, it's very difficult to do surgery right now.
I know. So I will say that my plan was initially to frame this and wait. And then I showed it to one of my partners, and he was like, fix it. I was like, what? Okay. Yeah, fix immediately. And his argument, so I ended up fixing it immediately. And his argument for that was you do your first dorsomedial incision between these two blisters and your lateral incisions are going to be fine. And she's 8 days out. So you're probably not going to get it well reduced enough. And you're just going to be waiting for 6 weeks for this in a frame. So I can't necessarily tell you that that was my first thought, but these are the considerations that you have to think about with trauma, especially for like a lady who's 76, you know, then you're committing her to another month in a frame, waiting for soft tissues to calm down. So I was a little risky with this one. I was a little bit more aggressive, and I made my incision kind of around those blisters, not through them. And in order to get my lateral column out to length, I actually put a frame on it in the OR, which is a really great technique, and you can either keep it on or take it off at the end of your case depending on stability. So I put a pin in the fifth, I put a pin in the calc. I'm sure most trauma thinks this is just like a Synthes mini X-Fix, and then I distracted my lateral column first. And what's incredible is that immediately I got my lateral column out to length despite her having this cuboid fracture. And what was also really cool is that it was able to correct the abduction deformity of this right away. So this is a great tool in your arsenal. Never be afraid to get a frame. And you can do this with a femoral distractor. If you're doing a tibial plateau, you can do this with an ankle distractor down low, but never be afraid to put a frame on. It made everything so much easier. And especially depending on who your help is in the operating room, this, I didn't need help. Like, I could just go do my work and everything was in the same position. So I did 2 utilitarian incisions, one dorsal, my second one along the line. I do it of the 4th ray, and that kind of gets you over to 2 and 3. If you need to do a 3rd one laterally, you can. I don't love fixing cuboids. They're a little bit unsatisfying, and so my thought was I'm not going to fix this unless it's unstable. So open reduced, pinned everything. And then I'm a big fan, and I'll show you guys my algorithm for this in a bit, but in an older person who's got a blasted Lisfranc like that, I'm a primary fuser. And so has anybody kind of heard the discussion or the debate on fixing versus fusing Lisfrancs? Plus or minus? Are people here fixers, generally? People are fixers. So I think it's very much kind of how you trained and what your specialty is. I would say that my trauma colleagues tend to be fixers, plates, screws, etc. Again, I'm using plate and screws here, but I'm using it to fuse. The foot and ankle community, I think, tends to be a little bit, we're not afraid of fusion because we fuse all the time. We constantly fuse. This is the construct I'll do for midfoot arthritis. And so there are some pros to fusing. If you think about it, fusing in an arthritic setting is very challenging. You're trying to get these angry sclerotic surfaces to heal. Fusing in a trauma setting is awesome. These love to heal. It's already fenestrated, it's broken, it's bloody, it's in a bunch of pieces. It wants to heal. If you're a trauma surgeon, you're trying to often avoid this for your cases. But we can take advantage of that and almost use that power to help us fuse. So the other benefit of fusing is that realistically, you know that this is going to get arthritis, right? And so you avoid a second operation or just a painful consequence of post-traumatic arthritis in this lady. The third is you never have to go back for another surgery to take out hardware. You just do it all at once. But the downsides is you got to make sure you fuse it well. You have to fuse it in the right position. Otherwise, they're going to be very unhappy with you. But I think the other thing, and we'll talk about this, is Lisfrancs, those midfoot joints don't have very much motion to begin with. So you can sacrifice that, and they still get a very good outcome. So I fuse this. I put on plates and screws at 1, 2, 3. You guys were talking, I'm a big plate person. And then I actually did nothing to 4 and 5. And you can see that they're still sitting well reduced here. So I actually took my frame off. It was sitting beautifully stable and well reduced. And so for me, even though she was a 1, 2, 3, 4, 5 fracture dislocation with a cuboid fracture, fusing 1, 2, 3 was enough to give her medial and middle column stability, and nothing else was needed for her. This was her at 3 months out. She was walking. She had no wound issues. She did great. But I will say that was an aggressive early fix for me. Any questions on that case?
What about outcomes?
Outcomes?
Instead of fixation.
Instead of fixing?
Because of, I think, if it's just ligamentous injury,
Mhm.
it should be arthrodese, okay. But in terms of fracture, I don't know. I think the outcomes is better in fixation instead of.
It's debated, and it depends on who's writing the literature. Because if you look at articles from foot and ankle surgeons, they'll all say the fusion patients do better. So it depends on who's doing the fusion and who's writing the paper, I think. I'll say anecdotally, I think a well-fused midfoot does incredibly well, but you have to be good at fusing. I think a primary fusion done by someone who doesn't do a lot of them, you may be better off fixing and then letting one of your partners fuse for arthritis down the line, because you can malreduce it and malfuse it. But yeah, clinically, so far, they do great. And I'll say that for my partners too. I also, though, came from a very fusion-heavy training, so I'm biased. But don't worry, I'll show you fixation too. So here's a very different patient. She's 33. She plays recreational rugby, and she had a turf injury. And so her pain is also on the top of her left foot. But really doesn't look too bad, right? Like 1 is pretty well in line, 2 is pretty well in line, 3 looks good on the oblique, 4, 5 are fine. I don't see a lot of translation. But when you compare her left side to her right, this is why standing weight-bearing x-rays are so important, is because I don't think you would have necessarily seen this on a non-weight-bearing x-ray. You can see that there's a little bit more widening here in the interval between 1 and 2 compared to 1, right? But it's subtle. It's a very different patient in x-ray from the last patient. Can I have you click on the left image for me, or the left MRI for me? Oh, hi, can you click on the MRI, please, for this one? Thanks. Yeah. All right, so this is her MRI. Here's the area where we're looking, and you can see there should be like a black ligament in there, and there's not. Can you click on this one now? I think I have the same thing here. Yeah. Okay. So, and then can you go to this image too? So this is a weight-bearing CT, or a standing CAT scan, where people stand in an image. And so her sagittal doesn't look horrible. And then can you go to this one now? But look at the interval between 1 and 2 here. It's wide, right? It's a little bit wide. And if you really wanted to be scientific and aggressive, you could get a bilateral weight-bearing CAT scan and compare. But I think for me, the difference, the MRI findings, the difference between the AP x-rays on both sides and that CAT scan was enough for me to think that this was surgical. So she also had, I don't think it showed, can you show this one again really quickly? Can you play this one again? Look, she also has a little bit of a flex sign here. It might have just scrolled through. Oh yeah, there she is. So she has a little bit of a bony avulsion or a flex sign there too. So this is a very, very different patient. So this is intra-op, and I want you to remember that the midfoot should be incredibly stable, right? Can you push this video? Yeah. So look in this interval right here. See how much kind of dorsal instability there is? And then do this one. And then this is me with my freer in. See how I can jack open that space? That shouldn't happen. There should be a ligament there. And all I did was make an incision dorsally. So for these, I'm going to show you a very, very different construct. So this actually for me just got 2 cross screws. So I fixed this one rather than fused. I do a home run screw here, and then she had, because of my intraoperative findings, she had a little bit of that intercuneiform widening. I also put a screw here in the intercuneiform joint. You just have to get a really good oblique view to make sure that you're not going into the other intercuneiform joint, which is why I know it looks short here, but there it looks okay. So for me, this type of kind of softer Lisfranc injury gets fixation. A fusion would also be incredibly reasonable here. You could do a first and second, but it seemed like a lot for her. fusing the midfoot. And this is one where you kind of have to talk to the patient, be like, you might get arthritis down the line, this might be a problem down the line, but why don't we try this, which is a much easier operation first. If you end up having symptoms, you can fuse it down the line. But you have, for this or the other one, you could have done plate and screws, you could have done cross screws, you could have done a fusion, and it all would have been acceptable, right? And it's all just kind of based on how you train, how you think about things. So for her, she actually just found out that she's pregnant, so we're not going to take out hardware or anything right now. But I would have no issue leaving this hardware in. I just tell her it might break down the line and we'll deal with it. But a very, very different way of thinking about Lisfranc. So yeah, you can fuse, you can fix, you can do whatever feels reasonable. I will say, oh, here she is. This is like the last x-ray we got before she told me she was pregnant. I will say that for her, the intraoperatively though, it is very important. So even if you're going to do 2 percutaneous kind of incisions for screws like this, I put a clamp between the medial cuneiform and the second to clamp down, and then I put in my wires. But even if I'm doing that, I will still always do a big open incision here to look at the joint, because that's going to be your key to reduction, not just what you see on x-ray, but you want this interval to be perfectly reduced. Okay. All right, so let's talk just a little bit about kind of generic things about Lisfrancs, even though I'm sure you guys seem to know a lot, which is great. So there is this ligament and bony structure, which causes the inherent stability of the Lisfranc. And it's this kind of keystone, right, where they're in this arch formation. And so each level is really, really important for your stability. The Lisfranc ligament, which goes from the medial cuneiform to the second metatarsal base, is right here, and that is incredibly important for the stability of your arch. There's also, though, you have to think about the plantar and dorsal aspects of your TMT capsules, as well as your interosseous ligaments. And so have a really, really low threshold of suspicion for Lisfranc injuries. And if you're looking for something small, but it's like if you have a capsule injury of 1 and a little flex sign of 2, like that's enough for surgery. You can always do an intraoperative fluoro stress test if you want, but regardless, these patients, these are unstable. Be aggressive with Lisfrancs. So there's the traditional mechanism for these is axial loading of a plantar flex foot. So they've reported a lot of this in, falls from height, sports injuries, crush injuries, etc. But it can really be anything. It can be a ligament disruption, like you were talking about, that ligamentous one only. It can be a fracture dislocation, like that first patient that we saw. A very common mechanism is this second metatarsal comes dorsally, and so a lot of times you can look for a dorsal subluxation of your joints. That can be very helpful too. The other thing that I think early on I was so stressed out about Lisfrancs, I was like, well, what do I do? How do I fix it? And one of the advice for my partners, this is the partner who actually told me to fix that one early, he just said, follow the energy. So just assume that your energy is going to come in medially and go somewhere laterally, and your job is to follow it as it peters out. So there's a very kind of traditional pathway of Lisfrancs where if you follow the energy, it goes through the first TMT and then goes through the second, and a lot of times we'll come to the third, fourth, and fifth. A lot of times if you get an MRI, you'll see at the third, even if there's no injury, they'll have lateral cuneiform edema and a little flex sign at the distal lateral portion of the lateral cuneiform. And sometimes for me, that'll be enough to fuse the third if I'm already fusing 1 and 2, because you know that that joint has had an injury as well. The other options, you can have a proximal extension. So you can have one where the energy goes this way, and then it extends proximally here into the inner cuneiform joint, and then sometimes can go into 2. And that's kind of like the patient that I showed you that was my rugby player, where she had some of that intercuneiform instability. You can also have what they call the NC variant, or the medial column disruption, where one might be okay, but you'll see energy and they might actually need either fixation or fusion at the inner cuneiform region, the naviculo-cuneiform joint, and then a home run screw. It's also really important to get comfortable with imaging of Lisfrancs. I showed a lot of advanced imaging, so CT, weight-bearing CT, and MRI, but you can get a lot from the x-ray. And I will say actually that I think one of my favorite x-rays for Lisfranc's is the oblique foot, because you can get a lot from looking at the second and third. So when you go to the first though, we'll start with that one. You can obviously look for widening between the first and the second. And you really want to follow this line from the medial aspect of the second metatarsal, follow it down, and then look at the medial aspect of the middle cuneiform. Those should be lining up. If you go to the lateral, you can look for this kind of zigzag sign where you see a dorsal displacement of the second TMT. But you can, as we showed on that first x-ray, that lady had a horrible kind of high energy-ish trauma to your point, but she didn't have this on the lateral. So you might not always see this. When you go to the oblique, this is, I think, where you actually get to see a lot. So the classic findings you're looking for, this red line here, you're looking for disruption of the medial column. You want to kind of follow the medial navicular, the cuneiform, and then the first. And then you're also looking here at a line from the fourth base to the cuboid. But you can see even here, like the third isn't lining up well. The second isn't lining up well. You can see a gap at the first. So I think the oblique view can a lot of times give you a lot of information. So in terms of your treatment options for the Lisfranc's, if they have less than 2 millimeters of displacement, or if they have a stable osseous or ligamentous injury, this is probably one of the rare exceptions when you can treat them non-surgically. But you really have to prove that it's unstable. And so, for example, I don't have her x-rays here, but I have a young woman who is like 38. She had a couple metatarsal fractures distally, which were non-operative. Completely non-displaced. And then she also had a Lisfranc tear on MRI, but everything was totally stable. And I think a really important thing, and again, I'll steal from one of my mentors, is that follow-up is a form of treatment. And so for her, I was like, okay, you're gonna go walk on this, and then you're gonna come back in 2 weeks, and we're gonna see if it displaces. And we did that again. I was like, if anything changes, we can deal with it down the line. But that was for her a nice way to reassure me that she had a stable midfoot. Certainly if a patient has a contraindication for non-surgical management, but for those, you're going to technically immobilize them and non-weight bear them. I will say that I do not do 10 weeks. I'd probably do earlier than that. And then technically long-term, you're supposed to give them some rigid arch support. Again, I think that's if the patient is willing to comply. Ultimately, though, if they're surgical, your goal is to restore stability of the midfoot. Stability of the midfoot is the most important thing. Again, these are going to heal, but you want the midfoot to be stable. And we started to touch on this a little bit of fixation versus fusion, but I think it's always important. This is a really great study from the 80s where they looked at how much the midfoot is supposed to move. And it's really not supposed to move much. And so, this is why I don't have that much of an issue with fusing the midfoot, is that these are non-essential joints, so to speak. They're only supposed to move a couple of degrees. And so for me, I have no problem sacrificing that to fuse a midfoot. I will not fuse the fourth or fifth TMTs. I will never do that because those joints you actually do need mobility for. So if there is an unstable fourth or fifth TMT injury, I'll pin it and then I'll pull the K-wires out at like 6 weeks in the office. Or you can put a frame on it. That's another option. So again, reviewing some of the pros and cons. So with an ORIF, technically you do maintain your midfoot motion, although I will argue that 3 degrees is not very important. It does save you a salvage option down the line. And you do keep that reduction at follow-up, which is always great. The downside is you often will need to remove your hardware. If you're doing a crossed screw construct, you do disrupt the articular cartilage, which may put you on the road to arthritis, whether you like it or not, and you ultimately may require a salvage arthrodesis. There is some discussion that these people may have a quicker return to sport, so that could go with your good outcomes theory. And I'll talk about my algorithm next. For arthrodesis, you don't need to take out the hardware. If you look overall, it's actually more cost effective for patients. You can still get that maintained reduction at follow-up, but you don't have as much salvage options and you do lose that few degrees of motion. So ultimately though, you have to decide which of these you want to do, and it depends on the patient. It depends on their age, their activity level, their expectations, what you feel comfortable with, but any of these are acceptable. And if you go to a foot and ankle conference, people will discuss all of these and have lovely debates about it. So my algorithm is the following. If they're young and if it's a major trauma, I will still fix. And I'll take plates out and I'll be like, listen, you might have arthritis down the line, but we'll fuse your midfoot later. If they're young and they've got a minimal injury, kind of like a sportsy Lisfranc, like the one I showed you guys, I'll probably do an ORIF with a screw construct, and I'll give them the option to remove the screws down the line. But if they're older and it's really major trauma, they're getting a primary 3D cyst. For me, it's a one and done. And those tend to heal very, very well. All right. So let's switch gears. Oh, perfect. We're doing great. And let's talk about challenges of ankle fractures. And again, I do not have a high energy ankle fracture practice. So I'll talk to you about some of the very fun, low energy ankle fracture challenges. So this is a 72-year-old. And I was on call that week, and we are an orthopedic only hospital, so with no emergency room. And so we don't get a lot of inpatient challenges. But this was a lady who was admitted to the spine service because she had spine osteomyelitis in her existing hardware there. And she fell down due to cord compression and weakness, and then she had this ankle fracture. So, any thoughts? Surgery, no surgery? Fix it? Yeah. Yeah. So they reduced her. I don't know if I have her reduction views, but it was beautifully reduced. I'll tell you that she's diabetic with like an A1C of, I don't know, 7, 8, something like that. And she initially, so she's sitting really well reduced in her cast. She undergoes IND cultures, revision of her spinal fusion. She gets a PICC line. Her blood cultures are negative. She's not septic. Her vitals are fine, and she's been stable. So it's been about 3 days. And her spine surgeon asked me, do you have to operate? It's not too wide, it's stable in a cast. And she's very agitated. She's like weird. She's like picking her skin off.
Yes, absolutely.
Oh, come on, guys. This is what happens to diabetic ankle fractures when they are not treated. 100%. Now, this isn't her. But we all know what happens. So I'm actually going to challenge you to say that diabetic ankle fractures need to be aggressively treated because otherwise they will have problems. And I would much rather fix her well now than deal with her malunited ankle down the line. So she got fixed, and I filled every single, typically a hole in a plate is an opportunity, not an obligation. For this, it's an obligation. She gets 3 syndesmotic screws. I put an anchor in the deltoid to further reduce her from falling into valgus. And we kept her on antibiotics. So for me, I think aggressive reduction, aggressive diabetic, keep her off of it for 3 months. That is kind of the mainstay for diabetic ankle fracture treatment. And she ended up doing great. She healed and lost a follow-up, and she was weird, but ended up being fine. So I'm actually going to encourage you to be aggressive with your diabetic ankle fractures, even knowing what could have happened. Yeah.
Why do you use 3 syndesmotic screws?
Because she's diabetic.
That's why?
Yeah. Diabetics, load them up. Heal with steel.
What about her glucose levels is regulated? Isn't that important? And HbA1c level?
Yeah, her HbA1c was like 7.5, 8, something like that. Ankle fractures, diabetic, need more metal, more time off. More time non-weight bearing.
I have a patient like that.
Mm-hmm.
Diabetic, type 1. One leg is amputated midfoot, and he had a fracture like this, but it was dislocation and fracture. He didn't want to treat it by surgery, so he wanted to try with cast. After 3 months, was totally dislocated the joint. We tried to do surgery. First, we did only with 2 screws in the syndesmosis. It was a failure.
Yep.
After 1 month, we did it with a plate in the fibula with 2 screws in the syndesmosis. It was again a failure. And now we don't know what to do.
Yeah. And again, that's what's diabetic ankle fractures are really, really challenging. They also, remember, people with diabetes, they have like diabetic brain. They don't know. They don't pay attention. They don't think about their health the way that they should. And so you have to treat them like they're going to walk on it right away and load it up. If I could have put in more screws higher up, I probably would have. If I could have moved my plate down a little bit, put in 4 syndesmotic screws, I would have. If I had to put 2 plates on it, fine.
Do you recommend more screws
I would do at least 3 for diabetics, sometimes 4.
3, 4?
Yeah.
What about primary TTC up to date?
Don't hate that idea. She was A1C of 7.5, gave her a chance. But I reserve my primary TTCs for geriatrics, but even then sometimes I'll be risky. We'll talk about that next.
If you didn't open it immediately to revamp deltoids, do you think it would affect the end result?
That's a great question. So this is another one where the foot and ankle and trauma people don't disagree, but have different thoughts. I am an aggressive deltoid fixer because I personally think it helps. But remember, my last lecture. So my interest is ankle arthritis, and I am very interested, even though I love doing replacement, of figuring out ways to prevent that. And I think that we do not recognize deltoid instability as much as we should. But for her, I did it because a diabetic valgus ankle fracture is going to hurt every inclination for her. This ankle is going to fall into valgus. If this collapses, it's going to fall into valgus. And so I am giving myself extra reinforcement to hold it from doing that. Yeah, I did. Actually, no. You know what I do is for these, I actually make a separate medial incision. The first thing I do is I put in my anchor, but I don't tie it yet. I clear out all the crap that's in the medial gutter that's preventing my talus from getting over the first place. Because remember, the talus wants to follow the fibula. The talus doesn't like to be close to the medial mal. Unless you get like a weird, some of the ankle arthritis cases I showed you before. But a lot of times there's crap, like the deltoid ruptures and then it furls up into the medial gutter. And if you've ever tried to reduce like one of these in the ER, it's like that sometimes they're easy, but now sometimes they're hard and you're just like, why won't it close medially? It's typically because there's crap in the medial gutter.
Obviously, you don't remove the joints.
No. Oh, she's going to die with these. Yeah. Yeah.
Sacrifice maybe the extreme part of those reflexes.
Oh yeah, I have no care about her dorsiflexion at all. She got bigger fish to fry. I'm never taking any of this out. For a young person, absolutely. But for her, if they're older, no.
When does she weight bear?
I kept her off of this for like 3 months, knowing, diabetic ankle fractures, more syndesmotic screws, 3 months non-weight bearing. Knowing that they might not follow that. You're shaking your head. Why?
3 months, non-weight bearing.
Diabetic ankle fractures, yep. They're hard. They're really hard.
So unlucky doctor to have a patient like this.
You think I'm unlucky? Oh, this isn't even a bad one. Oh yeah, you're unlucky, yeah. But if you look at the literature, 3 months off, 3 months non-weight bearing for a diabetic ankle fracture is technically how you can get better outcomes. It's hard. They often won't do it, but that's technically what you should be doing.
You always put the syndesmotic screws, or you do the CT scan before to examine?
For this, just put them in.
Always.
Diabetic, yeah. She's already proved that she's untrustworthy, right? Like this is a very different patient than a well-controlled diabetic with an HbA1c of 6 who gets it, right? This is a very different patient. She's picking at herself. She's got spine infection. She's falling over. Like this is a very different patient, right? So yes, I will absolutely do flexible fixation. I'll show you guys that in a sec. Yes, in my young patients, if I do syndesmotic fixation, I will take it out. But for this, she needs all the help she can get. Wow, I didn't know this would be so controversial. I love it.
There is any reason why you didn't use loft plate?
You totally could. I like the biomechanical stability of a posterolateral 1/3 tubular, but you totally could have. All right. Okay, so here's another one. Not regretting, but it took us a while to get there. Okay, so he's 94. He's got coronary artery disease. He's a household ambulator, and he's got a little bit of dementia, but he knows who he is. He gets confused about the year sometimes, but everything like that. And he comes in with this. And he's splinted pretty well, right? What do you guys want to do? Nothing? Okay. Don't hate that idea. Pan Taylor, you gonna do the TN? Or just TTC? Yeah, I must say, I saw him very early in my practice, and I was like, I don't know if I agree. I was like, I'm like terrified of operating on this guy. He's like really frail, really sick. And then I talked to the family, and I'm like, listen, Grandpa looks great. He's well reduced in a splint. Let's just see how he does. The family also doesn't know if they want to consent for him for surgery. They don't want to, he wanted a total knee like 10 years ago, and he was like too sick for a total knee replacement when he was 84. He's not healthier now. So they're apprehensive, I'm apprehensive. We're like, let's just see how it goes. So I see him back a week later, and his soft tissues look like absolute garbage. And they even look worse than this. He's getting blisters. This is actually from his initial visit, excuse me. He's got some blisters, but they're not horrible. The family wants to consider non-op. We agree to see him back in a week. He comes back 5 days later. I apologize, I don't have a picture. The x-rays look the same, but his wounds look garbage. Like he's on like Eliquis Plavix for his heart or whatever. His blisters are opening. He's got medial soft tissue wounds everywhere. Everything is leaking. And I was like, crap. So I admitted him, strict elevation. I put him on prophylactic antibiotics, daily wound care. I was like, we should probably fix this because I don't think that your wounds, I think the wounds for me were dictating this more than the underlying stability of the fracture even. And he's frail. I'll show you a picture of him at the end, but like, he's like, really tiny. And so his fracture is like 2 cell layers deep underneath his skin, and I think is starting to cause wound problems from down up. Okay, so I keep him in the hospital, we elevate him, we do wound care, we do Silvadene. Soft tissues are better, things are drying up, the family has agreement, okay, we're gonna do surgery. So I try to do things as minimally invasive as possible. I do a perc reduction of the fibula, put a nail in, perc reduction of the medial mal, 2 screws in, and syndesmosis. And I was like, I'm okay with this, you know? I didn't do anything tourniquet, just trying to protect soft tissues as much as possible. And I'm like, great, Grandpa's gonna be awesome. We're loving it, we're high-fiving. And initially he does well, but then a couple weeks later he comes back and his medial wound looks like garbage. So now a guy who was not healthy enough for 1 surgery now is going back for OR for his 2nd surgery for IND and antibiotics. So we do that, and his infection is better. Now he's got this new kind of lateral wound breakdown over the syndesmotic screw heads, and his wounds will not heal. And I've done local wound care, I've done vac therapy, and it doesn't work. So now what do you want to do?
Metal extraction and nailing.
He's only, okay, metal extraction, nail, okay.
Wait and see.
What's up?
Wait and see.
Wait and see, okay. I will tell you that before I couldn't feel pulses because he was so swollen. Now I can't feel anything. So I have him see vascular, and he gets an arterial, duplex, ABIs, PVRs, and he has total occlusion of his anterior, oh, and I meant to say posterior. He has total occlusion of like every single vessel in his leg. Oh my gosh, I don't know if he can heal that. He's 94. You're gonna cut Grandpa's leg off? These are like the challenges that I see in practice. And it's, again, I know it's not a car accident, but this is really, really hard. And amazingly, he's like, mentally, he's doing fine. Like, he knows where, he's like, oh, I'm still in the hospital. You know, it's like, this is the most alert he's ever been. And so I talked to my vascular colleague, and we decided to, I'm gonna take out the syndesmotic screws because he didn't really have a syndesmotic injury. I just put him on for additional fixation for the old geriatric ankle fractures. And then they decided to do an angiogram and an angioplasty of the right posterior tibial trunk. Great, so now he's on his 3rd surgery. The family is amazingly has not killed me yet. So now he's got so much blood flow, oh my gosh. But now the leg won't heal because he's got so much blood flow, he now has excessive moisture and his veins are not doing adequate backflow. Every time I put a vac on him, it melts off. He's moist. I have seen compartment syndrome from a revascularization procedure where these people get so much blood flow but bad outflow. But now he again, his bones, by the way, look awesome. And his bones have healed beautifully because they have all this blood flow. But his wounds, he's got this venostasis ulcer. So now what do you guys want to do?
In my country,
What's up? Yeah.
in my hospital, if this patient would come, the minimum of surgery we would do was only pin fixation.
Pin fixation?
Yes.
Yeah.
Cast.
Yeah.
That's all.
thing is, like, you saw my incisions, those were small. They're all like a centimeter.
But a lot of implants there inside.
I don't think it's the metal. Well, I will say the syndesmotic screws laterally. But the medial one, this is all medial. The lateral one looks great.
The soft tissue has no power to regenerate.
Reasonable. So I had him see vascular and wound care again, and then we started doing Una boots. And this was the trick for the venous compression. So this is him 2.5 months out. Everything is healed. His ankle moves great. This is him nicely healed. And this is him 8 months later, where he now walks 10 laps in the hall of his retirement facility, has no ankle pain, and actually came to see me with his knee arthritis again. He's still alive. So this is what blows my mind, is like, this guy, I mean, I will say I did threaten the wound care clinic, and I said, I will cut off my pinky toe and send it to you if you don't get him in. And so I will say, though, that these are challenging, and there's no textbook on what to do for these geriatric fractures. And I go back and I think, well, should I have done a TTC? Well, even then, you're still going to have 4 small incisions that might have become infected. Are you going to treat this non-op? I wouldn't, because he was getting soft tissue breakdown. He would have just gotten infected. And so I don't think there's an easy answer for these at all. By no means is this what I'm doing is the only right way to do it. But I think the big thing here is recognize your patient, fix the old people. And I'll tell you what I learned, and one thing that I learned, have vascular around, and don't be afraid to do what's needed, even if they're 94. So yeah, amazingly, he's doing okay. He walks, he just comes to, they carry him from his place in his wheelchair. Okay, so I think I learned my lesson, I hope. So this is a guy who came in this month who is 87, he fell on ice, he's got a cabbage, so he's had an open heart bypass, he's AFib, he's on Plavix and Eliquis, former smoker. Oh yeah, here's another one. So this time, I told kids and grandparents and or grandkids, I was like, we're not waiting. And I will say I kept my construct the exact same because I did like my construct, but I literally did this the next day. I'm not giving him he had no wounds, I'm not giving him any chance to blister. I'm gonna stabilize the bones immediately to get soft tissue coverage. I told Medis Anesthesia, you guys, I don't really care, we're gonna do whatever you want, or we're gonna do what I want, sorry, we're not waiting. And I fixed it again. And so he came back at 2 weeks. I've got a small fibula perc incision, a small medial malincision. This is what his legs look like. But so far, so good. So we'll see, I'll let you guys know. But I think for me, for the geriatric ankle fractures, here's kind of what I've learned. The first is that even though they're not the same as a hip fracture, I think you still do need to take them seriously, and you can see how long that saga can go. The second is don't be afraid to fix, even if they're frail or elderly. And I think that's one thing that I learned from these cases is that in modern anesthesia, like they're gonna keep them alive, you know? They can do regional anesthesia, they don't need to get general, you don't need to use a tourniquet, you can do this pretty minimally invasively. Like the patient's gonna live through the surgery. Fix ASAP, and then for me, for the old people, that means aggressively elevating and fixing right away. Minimize your incisions and your soft tissue disruption, again, whether you're doing a hindfoot nail or an ORIF. Again, I think you could argue to do a hindfoot nail for both of these. Either way though, you're gonna have to ask it to heal, and you're gonna have to make some type of incision. And so be prophylactic about your wounds. Wound vax prophylactically. I had a geriatric peel on that I did, and I literally just put wound vax on it in the OR, even though she had no wound issues. Wound care and vascular involvement. So that's my saga of geriatric ankle fractures, which continue to show up. And realistically, they're only gonna happen more. People are living longer, people are more active, even at older age, you're gonna see these. All right, so let's talk about how broken bones are sometimes not the worst part of the trauma. So here's a 34-year-old. He had a soccer injury fixed 1 year ago at OSH, which means outside hospital, the dreaded outside hospital. And he still has pain. Any thoughts? Mm-hmm. Yeah. Is that common a year out after a syndesmotic injury?
Yes.
Yeah, okay.
What means pain after?
What's up?
What means pain?
Oh, he has got pain at the anterior ankle joint, like it hurts.
Like it hurts, but he can do sports or?
He can't do sports.
I think the fibula union with rotation.
Maybe.
The fibula wouldn't fit incisura fibularis in tibia, I think.
Okay. Yeah, something about the fibula looks a little funky. Do you guys like the position of the syndesmotic screws or no?
They should be lower.
Those should be lower. I agree. 100%. I don't know what this one is doing here. It needs to be down here. And then this is a little bit of a what am I thinking, but when you see this is a Maisonneuve fracture, right? So Maisonneuve fracture, high fibula, syndesmotic disruption. Can you guys see what's like really, really common in a Maisonneuve fracture? Cartilage injury, right? Okay, absolutely. So we got an MRI. He's got a big osteochondral lesion medially. And then I also got a weight-bearing CT of both ankles. And look at his syndesmosis on this side. Don't look good. Fibula is rotated out. It's anterior and it's gapped.
It's still open.
It's still open, exactly. So now what do you want to do? Well, I'll tell you what I did. So I scoped him. There's his medial cartilage flap. There's his syndesmosis. You should not be able to fit a shaver into the syndesmosis. That means that the syndesmosis is too wide, even if there's screws in it. I cleaned out the lesion, and I am not a microfracture. I know it's commonly done, but I think that the newer studies show that they actually don't do worse, and when you violate the subchondral plate, sometimes you can make the patient worse. So I do a micronized allogenic cartilage matrix substrate, and I mix it with BMAC, bone marrow iliac crest, and I mix it in and I fill the defect with that. So I did that, and then I also revised his syndesmosis. So I took out all the hardware, I clamped it, and I put in 2 screws and a plate. This isn't my favorite construct for a young active person, but I was a little bit worried that flexible fixation wouldn't cinch it down after it had been wide for a year. So I did this, and then 6 months later, I switched him to flexible fixation because he did want dorsiflexion and want to go back to sports, and he's not 94. So I did think, and he felt better, so he's back to soccer with us. So you can see that you can even see a little bit of the fill. What's that? Yeah, tie ropes, flexible fixation, exactly. Why did they not do it, or why did I not do it initially? Why me? His syndesmosis was so wide, and with flexible fixation, you still have some mobility, and I really wanted to suck everything down. The other thing that I did is I also lagged my syndesmotic screws to get further compression. When the syndesmosis has been wide for a year like that, it's really hard to get it closed. It's really hard. Like even with a clamp, it was still pretty wide. So it's really challenging. So I used my screws to almost help me get my reduction.
So you use the tight rope after 6 months?
Yep.
What for?
Why not?
Should be healed by
Yeah, should be healed. Why not? It's been wide for a year. Plus, if you're taking them out anyway, it takes 20 seconds to put tie ropes in. You don't necessarily have to, but I get to sleep at night now, so. I often will for my really unstable syndesmosis, who I put screws in, I'll put tie ropes down the line. Because my biggest fear is I'm not worried about it being over compressed. My biggest fear is that he's gonna go wide again. All right, okay, so another one, he's 50, he's a dad, he bikes, he fell off his bike. Okay, so pretty straightforward, you know. Yeah, man. Well, this is a stress view. But he was surgery. I stressed him in the office too. I'm sorry, I don't have that view. So he had a little tiny posterior malfracture, too small for me to, I think, get a plate in. Although I am pretty aggressive about fixing a posterior mal, even if it's smaller than 20%. I will fix it if I can get anything in it for stability and syndesmosis. But for him, I scoped it, and look at that. He's got a full thickness cartilage lesion medially. And I was like, how do you get that? It's a pretty not bad injury. And I realized from my stress view, this spike of the fibula was directly in the talus. So for him, he also gets an acute cartilage repair. Again, same thing. So for all my ankle fractures, unless they're like the grandpa, I scope them and I just prep out the crest at the same time. And if I see something like a scope takes 10 minutes, I evacuate the joint because we heard about how hematomas can make ankle arthritis worse. And I will take BMAC if I need it.
So you do first arthroscopy, and after that you fix the fracture, or you do the fracture and after that you do the
I do cartilage first, and then I fix the fracture. I let it dry in traction for the first 10 minutes, and then I go to the fracture. If I really wanted to be aggressive, I could go back and put a scope in and check my reduction, but I don't really want to disrupt my nice little, we put a VistaSeal or a TeSeal, a fibrin glue on it, but I don't really want to go back there and disrupt it and shove my scope in, etc. Yeah, I do BMAC mixed with the cartilage matrix. And so then he gets kind of a straightforward fixation. I just put in one tightrope for him. So one thing that's just really interesting is that if you look at cartilage injuries and ankle fractures, if somewhere upstairs of like 80% of ankle fractures, especially if they're a bimal or a trimal or a Maisonneuve, do have a chondral lesion. And so I don't think we've proven yet that this makes his outcome any better, but I don't think it makes it any worse. And again, I am someone who treats ankle arthritis, and so my interest is trying to figure out, well, how do we decrease that risk? I will tell you that my partners are variable in terms of what they scope. We've got, like most of the young guys do, the older guys don't, but even the older guys will say that they will scope every Maisonneuve because you just can't see the cartilage otherwise. And Maisonneuves have a really high incidence of cartilage injury. And so I think that patient who you guys saw 2 cases ago was treated by a trauma. So like, for example, one of my trauma surgeon friends will send me Maisonneuves because he does believe that they should be scoped. He just doesn't scope them. So he'll send me his Maisonneuves. So I do think that's one, if you're going to scope, that's the one to scope. Oh yeah, so we said this. So I scope nearly ankle fracture, unless they're like the diabetic geriatric. I've got different goals for those cases, right? I prep out the crest. If it's only lateral and medial work that I have to do, I'll position supine. But if or posterolateral work, I will position them lateral, and you can usually just externally rotate the hip and get into scope. And then I just have my assistant pull manual traction with a strap, or you can use a Curlex around. Actually, ankle fracture is the easiest one to scope. It's really easy to get the scope in. It's loose. It's fine, So it's a great ankle to scope initially if you're trying to learn how to. It's not hard. And then even my arthroscopy cautious cherry grease, scope every Maisonneuve. Okay, so I will say though, this is one thing I don't have figured out, and you can grab me later if you have ideas for these. So Lyndon Mason writes a lot about the 2B posterior malfragment, where it's not just a posterolateral fragment, like we all know what to do with that, but they also have this posteromedial fragment. And if you follow his literature, and I do believe this because I've seen it intra, you do have to reduce and fix the posteromedial fragment first. Otherwise, if you do the posterolateral one first, you come around to the medial side and then your posteromedial fragment's not reduced. These are awesome to do prone. It is so easy. You look and see everything, and it makes your reduction so much easier. And this isn't my x-ray. I should have brought one. I actually just did one Friday. But plate the fibula however you want, do your posterolateral plating, and then I usually do like a 1/3 tubular in the back, and then I do a 1/4 tubular for the smaller piece. But what I don't know is how I'm going to scope these and do it prone. I still don't have that figured out. So if anybody has ideas, let me know. I tried doing it posterolateral, where you go medial posterolateral, and I don't like it, position lateral, and I just haven't figured it out. So maybe I don't scope these, I'm not really sure, but I think these are challenging. If anybody knows Lyndon Mason and want to ask him my question too, let me know. So what's on deck next? Oh, this is just a case that I have, I'll just do quickly. I haven't started this one yet. She came into my office a couple weeks ago. So she's 60. She had an ankle fracture fixed 6 months ago at the dreaded outside hospital. And so their syndesmotic screw her syndesmosis is wide. Her medial mal is probably not super well healed, although I think it is on CT. I don't understand that screw. It's not doing anything. It's whatever. They needed one right here. So anyway, now she's got ankle arthritis and her foot is flat. And so here's her CT. She's actually healed. Again, her syndesmosis is out here in the breeze. And so if you guys remember this case from before, please take ankle fractures seriously in patients with flat foot because they will collapse into valgus like this. And one of my partners hasn't published it yet, but does think there is something to a wide syndesmosis in a flat foot patient. It is a really, really tricky case. So options for her. She saw somebody who recommended ankle fusion, but I like pain. And so I think what I'm probably going to do is take down the malunion, revise her syndesmosis, do a flat foot reconstruction at the same time, and then do an ankle replacement in like 6 months. That's probably what I'm going to do because I really like to save her ankle if I can. It's just a lot. It's a lot.